Thank you so much, Sharita, and thank you to the audience for your attentiveness. As any one who's worth their salt, any organization, yes, we are going to do a small survey at the end, which will give you access to after this panel that's going to come up now. And I won't speak too much other than to introduce the moderator for the panel, Dr. LeKeyah Wilson. And I'm going to leave it there, Dr. LeKeyah, and you take it away. And, we have an amazing panel that she will introduce and talk to you more about. Let's put it this way. Everybody's a doctor, and they're going to deal with the issues. And from a results point, I'm sorry, from an improvement point of view, how we close various health disparities. This conference is not about talking about the problem, but how we fix it. So, Dr. Wilson, good morning again. Welcome. The floor is yours.
Good morning, everyone. Thank you so much for that warm introduction. So I want to be very mindful of time, and we have such a fantastic panel. So I want to just go ahead and start. So their bios are for each of our panelists are on the website if you want to get more details about who they are and what they do. Dr. Carolyn Jacobs is a well-respected pediatrician with Rochester Regional Health, with an expertise working with diverse population during her career, including the refugee population, LGBTQ youth, urban and suburban youth, along with the deaf and hard of hearing. Dr. Jacobs, your first question. Pediatricians play a crucial role in early intervention and identifying symptoms and behaviors related not only to development, but also mental, social, and emotional health challenges. Please talk about building trust with parents, caregivers, and key considerations for partnering with parents and caregivers of color, especially in low-income communities.
Excellent. Good morning. A pleasure to be here. And the question is a phenomenal one, especially as the keynote speaker put to us, the call actually has been made, and we do need to respond to that call and that alarm. One of the things that I really stress that's important is the need to respect individuals. As long as you give respect, you will receive respect in return. It's so important for families, particularly people of Black and Brown communities, feel respected and feel that you are a person who is willing to listen and to begin to understand. Even if you are not completely aware of what is going on in their community, the need to be there in the moment is essential. So there are key things that I recommend. One is to make sure you have a listening ear. We actually have 2 ears and 1 mouth. So we are supposed to listen just as hard, if not more so, than what we speak. And that's really important because our families come to us and they're vulnerable, and we do want to be able to help. So make sure you're listening intently. It's also important to inform your families that you are going to provide them with great care. And if they ask, how is that so? You can always tell them what's really important is to talk to people in the village, because word of mouth is essential. I often ask families, how did you find me? Well, nowadays the internet is very, very successful. So that's one spot. Oh, I asked so-and-so, I asked sister so-and-so at church this past Sunday about you. So word of mouth is always, always helpful. So you definitely want to make sure that you have a positive presentation in the community. And as Ms. Bullock said, people can see me out in the supermarket. They can see me at the public market, and I need to have my A game on. I definitely want families to see me in a positive light, because again, that respect is essential, and I give that respect so that I can receive it. And the other important piece, in addition to listening and making sure you're there in the moment, is to understand the role that the family plays for our children, because it's so important. Anytime I see my pediatric patients, they are usually with a caregiver, be it the mother, the father, the grandmother, cousin, auntie, uncle, you name it. There are people within the village. So you have to understand what role those members of the village play. Because I will guarantee you, if grandma said, put the food and the cereal in the bottle, you better put it in the bottle. And it doesn't matter what the pediatrician said, because we always respect our elders. So again, it centers back to respect and understand what role those members play. And there are many a times I will ask, what is it that grandma has said? And I invite grandma to speak to me. We have speaker phones. People come in, we can FaceTime. I ask questions because when you are there and you offer that extension to the family and recognize that this is a network, we are working together. Families are not there in isolation. So those are my suggestions. Just give respect, you will get it. Be in the moment and respect people in their spaces, and then understand who is in their village, because that's how children move forward.
Thank you so much for that, Dr. Jacobs. Yes, I've got my pen and paper ready because I know I'm going to learn so many pearls. Being there in the moment, listening, giving respect, understanding the role of the family, and understanding what the village is. Thank you so much. For our second speaker, Dr. Edith Williams is the founding director of the Office of Health Equity Research and is appointed as the Dean of Associate Professor of Health Equity Research. So for your first question, Dr. Williams, if we're going to achieve equity in research and culturally responsive evidence-based models, we must begin to build trust and offer a grassroots approach to educating communities of color about the benefits of research. Please offer 2 system levels and 2 individual levels of strategy to achieve this.
Sure. Good morning. And thank you, everyone who has already spoken ahead of me. This has been phenomenal already. So at the crux of this question, I think there's a facilitating of transparency that needs to occur. And that in turn leads to authentic conversations, which can enable relationship, and then we arrive at that desired level of trust. So systems need to be held accountable with regard to investment and their presence. Earlier this week, Dr. Sharon Brangman presented Department of Medicine Grand Rounds at the University of Rochester Medical Center, and she described an effort to have community research liaisons present in the upstate community. And these were community members who would just be outdoors. And they called this effort Coffee and a Bench. They would be sitting outdoors. They would invite community members to come and simply talk over a cup of coffee about research. This was ahead of an ask. They weren't asking for samples. They weren't asking anyone to complete a questionnaire. They were simply there to engage in an authentic conversation about people's reservations about research, their perceptions of the university, their perceptions of research, and there to answer questions that people may validly have about research activities. And this was an effort that Dr. Brangman and her group had to piece together with funding from different sources. But this is exactly the type of effort that our institutions can invest in, not only financially, but also by providing the time that our providers, our faculty, and other staff need to engage in this type of very valuable interaction. I am coming from the Medical University of South Carolina in Charleston, and there we have a very robust Sea Island population. And so our rheumatology group there would regularly be present in the community at various events, Gullah Geechee food festivals and celebrations of different kinds. They would be at different educational events at libraries. So while they're sitting, putting fishing nets together with children, they're able to talk about what they do at the Medical University of South Carolina, the types of trials that they're running, and not in a recruitment effort, but they're there and they're taking advantage of that opportunity to engage in authentic conversation with community members who may benefit from the type of work that they're engaged in. So presence in the community ahead of any kind of ask to be able to have these types of conversations is critical. And not just sending out our Black and Brown professionals, everyone needs to be part of that effort. When certain groups stay away, that could be interpreted as disrespect, as disregard, and it can actually do more harm than good. We have a lot of groups that are very well-intentioned. They're like, no, we should send out the folks that our community members will trust. Well, no, staying away can actually be a hindrance. It can deepen those chasms between groups, and it can create doubt and skepticism around these conversations of research and what research holds for different communities. And while that type of interaction and engagement and presence is a personal choice of our providers, our faculty, our staff members, it is also the investment of our institutions. They have to value these activities enough to invest funding, sponsorship, and also free up the time of our health professionals to be present in these communities.
Thank you so much for that, Dr. Williams. Transparency, investment, and presence in the community. I really do like the coffee and a bench model. I think we should implement that in so many aspects of education and medicine. Dr. Gina Cuyler is a board certified internal medicine physician who is currently serving as the Vice President of Health, Equity, and Community Investments for Excellus Blue Cross and Blue Shield. Welcome. Your first question for the morning. The United States has spent millions of dollars on healthcare disparities and implementing initiatives to address chronic health issues and improving health outcomes among marginalized populations. While there may be progress, we are still falling behind with preventable deaths in certain areas, including maternal health and mental health. From a medical systems perspective, offer 2 strategies to continue to move us forward through the lens of equity.
Well, first, let me just say thank you to everyone for allowing me to be a part of this program. I'm so honored to be here with you all. And in response to your question, let me preface with this. It has been said that a rising tide lifts all boats. But the historical data of the last 2 years shows us that you can enter a season with a strong economy and a healthcare industry that accounts for about 20% of GDP and come out with poor health outcomes. The armada of healthcare and healthcare outcomes could not withstand the gale force winds and the waves of the COVID-19 pandemic. We have seen the deaths and the disparities. Consider this. If you have a boat, you can put so many gold bars into the boat that you eventually sink the boat. Why? Because at some point you need to check the data. The data tells you what is necessary, what is helpful, and beyond what capacity the boat will sink. At some point, you need to assess the situation. Well, the situation today, my friends, is that what we're doing is not working. I have heard it said that insanity means doing the same things over and over again and expecting different results. Well, this right here, right now, is a point in time where we need to change the paradigm. We need to understand that our patient healthcare is sick. In some parts of our country, healthcare is on proverbial life support. So how do we fix that? Well, there is hope. It is one thing to say that health insurance companies have a role, and I agree. But I would go further and say that we all have a role in modifying our current situation and getting our patient healthcare on the path to optimal health. So the first strategy to continue to move us forward through the lens of equity is to collect the health equity data, REL, SOGI, SCOH, REL, race, ethnicity, language, SOGI, sexual orientation, gender identity, and SCOH, social determinants of health. Once we collect the data, we can use the data to ensure people get the care that they need and the care that they deserve. We understand what disparities exist, and we must identify the root causes of the disparities and create actions accompanied by metrics that define what success looks like. Part of collecting this data involves engaging, educating, and empowering all stakeholders. I'm talking about health insurers, healthcare providers, patients, community-based organizations, legislators, and employers to do better. In addition, there must also be accountability. I've often spoken of the role of hearts, minds, market share, and mandates when it comes to promoting opportunities for everyone to have optimal health. Some people will act because it is in their heart to improve health outcomes. Some will do what the data indicates should be done because it is logical to their minds. Others will do what makes good business sense and will gain them market share. And finally, there are those who will only act if they are mandated to do so. Having metrics to improve health outcomes that build in accountability for achieving those outcomes is critical to changing the paradigm. Second, we must commit collectively to the quadruple aim. The National Committee for Quality Assurance has said that there is no quality without equity. And when I think of quality, I think of the quadruple aim. The 4 objectives of the quadruple aim are to improve the health of the population, reduce costs by reducing waste, improve the individual experience of care, and reduce clinician burnout, which is so prevalent. If we can, as stakeholders, all commit to this work, I believe that we can begin to achieve health equity.
Thank you so much for that. Yes, there's no quality without equity. Yeah, I wrote that down and underlined that a couple times. Thank you so much for that. So for our next speaker, Dr. Paula Cupertino is from the University of Rochester. She is a professor of public health sciences and oncology and is with the Wilmot Cancer Institute. She is the first associate director of community outreach and engagement. Good morning.
Good morning.
Your first question for the morning is: cancer disparities among our Brown and Black community are the results of many factors. Please talk about the disparities in diagnosis, treatment, and outcomes, and how the Wilmot Cancer Institute approaches to eliminate these disparities, and how the community informs or changes Wilmot's Cancer Institute's approaches to eliminating these.
Thank you. How many hours do I have? Thank you, Jerome. Thank you, LeKeyah, and thank Sharita and the panelists who are calling us with responsibility, accountability, urgency, and action now. Thank you. You inspire me. I'm here. I represent the COE, the Community Outreach Engagement at Wilmot Cancer Institute, in my team, a stellar team, diverse team, culturally and linguistically sensitive. Disparities are real. There are people that, as Sharita called us, we're talking about individuals as we look at populational level. And just to summarize how unjust and unacceptable are the disparities here, I want to call attention for one indicator: the cancer incidence, putting all cancers together. Wilmot takes care of a catchment area of 3 million people. Most of them, a large amount, here in our region, 27 counties. If we were a state, we would be the second worst state with cancer incidence. Just to give you an idea, Kentucky, the worst, 510 cases by 100,000. Wilmot catchment area, the 3 million people, 508, the second worst. Rochester, 520. The state, 483. The country, 453. What is happening here? That we are not benefiting from the advancements that we have done scientifically as a society to control cancer. Mortality and incidence in our catchment area has remained higher than the state in the country for the past 20 years. What are we doing wrong? Why? Why is this happening? 9 of the 10 cancer most prevalent are higher than the state in the country, 9 out of 10. The risk factors are in alarming rate. Smoking in the Black community is 27% in Rochester. These numbers is higher than many other communities, Black communities in the country. The same about Hispanics, tobacco, driving force, and the populations that are bearing this burden, the individuals that are bearing this burden, that we need to pay tailored, dedicated attention, especially the Black community here. What is Wilmot doing to address the unacceptable? Well, first, I'm hearing a lot about data. Wilmot has dedicated resources and to develop their own tool that soon is going to be available to all of us and with a community interface. We have brought together multiple databases, and they're going to be organized in what we call Canvas, in which will allow all of us to zoom in where is the need at the zip code level. And with you, in making me accountable in Wilmot, we are going to dedicate attention, resources, and understand that one size doesn't fit all, that we need to go above and beyond, spend time there, as you all have said so well. And in the Office of Community Outreach Engagement, we have done this in creating many opportunities to do this. One, we guide ourselves by this data that comes from Canvas, and the need is here. With this data, in a very active, action-oriented 27 community members that come together every month, that have voted on how they're going to work with co-chairs, with working groups on what are the priorities. They communicate not with Paula of our office, directly to the leadership. So the leadership leads, Dr. Friedberg meets with them. They set the priorities and tell, this is what we need. They represent the community, and we need many more of you. We bring this in, and this is how Dr. Friedberg leadership have made significant changes. We now have, just this past year, 6 new researchers who have never tailored their approach, even from the basic science, that are now addressing disparities. Because we can't continue looking at pancreatic cancer, for example, the third cancer killing our communities, knowing that they affect Black and Latinos at a higher rate, and just watch that and conduct a study that doesn't take into consideration the community voices. So we have community advisory boards. Their role is to meet and to guide. We have 9 community advisory boards, more than 58 members. They are helping us to say how we need to conduct, how can we overcome the social determinants of health, how we must have diversity in our research body, in our team. So this is why the community is leading us at Wilmot. Our clinical trials, by listening to the community, we have been able to grow participation in a couple trials from 0% Black and Latinos to 25%. This is how we are going to be able to understand why and what are the therapeutics, the diagnosis, the preventions that we need to do, only if we add disparities to the existing business that's done. Last but not least is educating and outreach. This past year, led by Dr. Candace Lucas, that you all very familiar, we have reached more than 5,000 individuals. We have established a location at the mall where we hang out and talk at Greece Mall. By doing that, we have identified individuals that are due for their colorectal cancer screening for 10 years, 15 years. There we are listening, learning, that we need to do more and better, that we can't stop here. And I know we are in a good path with the Wilmot strategic planning, and with you, we can do, we must control. We must do now with individuals and communities, but we need to control and be able to affect at the populational level. 5-10 years of now, the only way we can get there is with you in learning, in sharing, in collaborating. Thank you.
Thank you so much for that, Dr. Cupertino. I think this day and age, we have all been impacted, either ourselves or knowing a loved one that has had a diagnosis of cancer and had to deal with that. And the numbers that you share are astonishing. If we were a state, we would be the second worst state in the country. That is just wow. We're going to turn back to Dr. Jacobs for her second question. Provider bias, social determinants of health, policy barriers, all can impact quality of care and medical outcomes. When engaging with families of color around mental health and trauma-related conditions, what are two key factors that every professional needs to understand when providing care?
So to answer that specific question, I think it's really important for people to identify all the social determinants of health. And one thing that is essential is for clinicians, and not just people who are really servicing our patients, but people at the front desk, the first people that patients see when they walk into the building, to our medical assistants, to our nurses, and ultimately to us providers. It's important for us to be aware of what is called trauma-informed care. Unfortunately, I would say that is something that is not traditionally taught during traditional training programs. So during medical school, nursing school is probably a little bit different, and same thing with PA, physician assistant programs, it's probably a little bit different. But definitely when I was training decades ago, I did not know what trauma-informed care was. And had I known, and if I was more aware of what was going on in those 5 guiding principles of trauma-informed care, I think it definitely would have made a difference. You can't necessarily teach someone how to be sympathetic or empathetic, but if you let them know what they need to think about every time they go into an exam room or every time they even talk to a patient, that's important. And those guiding principles are to ensure that your patient feels safe. And that's key. They need to be safe physically and they need to be safe emotionally. So safety is one of those guiding principles of trauma-informed care, along with choice, reminding that they do have a choice in what decision can be made. Also, we want to collaborate, like I talked about earlier. We want to work with the individual and whoever else they deem important in their life. And trustworthiness, there's not enough to be said. If you look back in our history, unfortunately, the medical system has not been a positive one for people of color. We have not found providers to be very trustworthy. So just like respect, we have to earn our patients' trust. And as was mentioned, transparency is key. And the other piece is empowerment. For our patients to feel that these are their choices and that we are wanting them to be in control of their body. I tell my patients all the time, you are in charge of your body. Nobody will know it better than you because you live in it. Even though I may have the background and the knowledge, I do not live in your body 24/7. So when you tell me something, that is the reality. I work with what you tell me. So when I have mothers, and many a times people have experienced trauma, not just from their own personal lives, but other times from other healthcare professionals. And unless I know that, I won't have any understanding of where they're coming from. So people may write off parents as irritable or angry, but we don't know why. And sometimes it's okay to just ask. And I always want my families to feel empowered. I need these parents to understand that these are your children and you make these choices, but I'm here to work with you. I kind of stole this quote from my friend who's in family medicine, and she says to the families, you are the CEO and I am actually your healthcare consultant. So you utilize me in whatever way you deem appropriate. And by telling the families that they are in charge, that's the beginning, and that I am here to help along the way. And then that second component that I would say is critical is to be your patient's advocate, because that is key. They need to know that you are going to be there to provide support and encouragement when they need it. There are times when we share bad news, there's times when we share good news, but we always want them to know that we are rallying and we are providing support. So that is essential, making sure that we understand what trauma-informed care is, and definitely learning to advocate and be the best voice that we can be for our patients and families.
Thank you,
Thank
Dr.
you.
Jacobs. You are amazing, and it's clear why your patients love you so much, and we would love to duplicate you, but we cannot. And so I think one of the things that you really highlighted is that we need to train our providers in trauma-informed care to provide better care for our families and community. Thank you so much. Dr. Williams, your second question. Systemic racism is real and has historical implications in both the medical community and higher education. Promoting STEM, research, and healthcare careers must begin early. What roles can colleges and universities play as we work to expose Brown and Black youth to research and exposing them to a variety of career paths?
Thanks, LeKeyah. And I realized after I had spoken before that I actually skipped the second part of my previous question. So if you will allow me, I would like to merge my responses and continuing the conversation about educating communities of color about the benefits of research and also exposing our Black youth to opportunities to engage in research, healthcare, et cetera. So I wanted to begin, and I'm not trying to impose my religious beliefs on everyone, but thinking about this question brought to mind the scripture for me in Deuteronomy. It is in response to the commandments that were given, if you believe in that. And it says, impress them on your children. Talk about them when you sit at home, when you walk along the road, when you lie down, and when you get up. This has been a mantra in my family for spiritual matters, but it can also be applied to our individual conversations that we are having with our children, with others about research. This is about holding ourselves accountable with regard to capitalizing on opportunities that occur naturally. So I have 3 daughters who are always asking me what I do. And I remember there was one instance when there was a cannabis trial that was being run among our lupus patients in South Carolina. And of course, that piqued their young interest. And I was able to explain to my daughters that there are some treatment options that have negative stigma, particularly in certain populations. And we engaged in a cannabis trial in an effort to see the impact on chronic pain in our autoimmune patients. And we saw such swift and significant results that we had to end the trial early because there was no need to continue. Everyone who was in the intervention arm did significantly better in a short amount of time. And I asked my girls to imagine demonstrating that, not in just 50, but in hundreds, in thousands of color experiencing chronic pain, who have run into stigma around the treatment of chronic pain. That evidence could break down such stigma, could allow us to recommend and ensure access to effective treatment and make sure that that effective treatment is safe and reliable. And I asked them to then imagine without that information, without that evidence that research provided, where we are left. And that really got them thinking about not only the work that I do personally, but about research in general and why it is so valuable. And that is just a conversation that I had with some teenage girls. We can also ask about and share our own experiences in research. I was speaking with a colleague who works with a largely English as a second language population, and she was telling me about their hesitance to go to the hospital and how people in this group she was working with shared with her, well, we just have one representative go to the hospital, and then she comes back and tells us what we're supposed to do. And there's such power in receiving and understanding personal stories and personal experiences. They can educate, they can motivate us, and they can shift our perspectives. So that goes to that answer about our individual, what we can do as individuals to promote educating communities of color about the benefits of research. Now, going to the second question about what we can do to help our Black youth explore professions and opportunities in research, healthcare, and STEM. We have wonderful existing programming. We have STEM curricula in schools. We have shadowing and employment opportunities that we extend to students. We have summer research opportunities that are part of various pathway programs and other immersion programs. But many of those programs are geared toward our high schoolers, and they have limited reach. We may be focusing on one school or a cluster of schools. And I love the emphasis on beginning early. I love, Sharita, I'm going to put everywhere, how are our children? I just love that. That resonates with me. So I love this emphasis on beginning early. We need to expand our efforts and find creative ways to reach our kids where they are and draw parallels between what our kids are interested in and the relevance of those things to STEM, to healthcare, and to research careers. So I think of my stepdaughter. She wants to take selfies all day and be an influencer. This is what she's aspiring to be these days. So I can have a conversation with her. Well, do you know that there are whole institutes dedicated to food imaging to help individuals and families to have better nutrition and healthier diets? There are actually professionals who work with them about how to take pictures of their food and document their food habits. This is a way that skill that you are nurturing could be used in this type of field. These are things that some of our kids may not know. We also have dentists and other oral health professionals who are helping families to take images of their babies' mouths to try to intervene early in dental health issues that may develop very early in that stage of life, that families can then document in a way that's accessible and convenient. And this then can facilitate conversations with dentists, with their other providers about preventative steps that they may be able to take. And this is another way I said, I'm sure you didn't realize that even our providers and researchers are engaged in those types of digital activities that a lot of our kids are interested in. So I was able to link that natural propensity in our youth with the possibilities of future careers. And so I think we need to continue to be creative in those ways, find creative ways to share those opportunities and those intersections.
Thank you so much for that. Yes, engaging our youth in the conversation. I think that's important, and sparking their interest early on and meeting them where they're at. I think that's awesome. Thank you so much for that. Dr. Cuyler, your next question. Health plans have a role as we work to advance culturally responsive care and address the social determinants of health. Please give 2 examples on how Excellus is leading in these areas.
Well, I'm very excited about the work that we are doing. Our mission is to help people in our communities lead healthier and more secure lives through access to high quality, affordable healthcare. And that resonates with the CDC's definition of health equity, in which everyone has the opportunity to have optimal health. In 2022, I created and we launched our enterprise health equity strategy, which will allow us to address the disparities due to 80% of the drivers of adverse health outcomes that exist outside of the clinical arena. We are leading in this space in a couple of ways. First, we recognize that bias in healthcare is a driver of poor health outcomes. We have, as part of the vast work that we are doing, a commitment to reduce racial disparities. And this includes racial disparities in maternal health. Through a partnership with the Blue Cross Blue Shield Association and the March of Dimes, we offered free bias in maternal health training to all of our healthcare providers through live facilitated trainings and e-learnings. In addition, we also offer free provider trainings that cover topics such as cultural competency, poverty competency, domestic violence, and suicide risk and assessment. Second, we recognize the rising disparities in maternal health in Black and Brown women. So this summer, we launched our maternal health equity member and community health improvement grants and invested almost $1 million over the next 3 years to support programs that address disparities along the maternal health continuum. This includes infants, These programs include work that supports pregnant and new patients, parents with education, advocacy, housing, transportation, food, and so much more. This work is critical because of the intersectionality of the factors of race and ethnicity and language with social determinants of health when it comes to addressing maternal health outcomes. In addition to these awards, we support the work of the on-the-ground, grassroots, community-based organizations that tirelessly work to address the disparities due to social determinants of health in our communities. We provided funding through our Health Equity Awards in 2021 and 2022. In 2021, to organizations whose initiatives focus on reducing health disparities and improving health equity in communities of color, especially Black and Latino communities, where historic and current racism and discrimination continues to result in a higher burden of health inequities and social disadvantages. We requested that applicants have an intersectional approach when possible. Organizations had to specify how funding would measurably assist in improving racial and ethnic health equity outcomes. Some of the emphasized initiatives included improving the community's physical health and mental health, reducing social disparities in healthcare, and ensuring access to healthcare. In 2022, our Health Equity Awards focused on support for underserved people with health disadvantages due to race, ethnicity, disability, sex, gender, and/or rural disparities as the areas of concentrations. And this year, I'm happy to announce that we will have our Health and Wellness Awards that will concentrate on supporting programs that address conditions such as maternal health, behavioral health, diabetes, et cetera, in an intersectional way that addresses barriers resulting to race, ethnicity, language, sexual orientation, gender identity, or social determinants of health, all of which contribute to poor health outcomes. We're doing a lot in this space, and we're looking forward to partnering with our community to achieve optimal health for all.
Wow, that's amazing. I'm hearing trainings, programs, awards, investing in the community. I'm going to have to go on your website to get a list of all the fantastic things you are doing in the Rochester area. We are so blessed to have you. Thank you so much. And for our last question, Dr. Cupertino, let me scroll down got so excited. For my last question, cancer research in minorities and marginalized communities are advancing practices that are culturally responsive, but this may not be the main priority in our region. Please discuss initiatives and innovative approaches that the Wilmot Cancer Institute has implemented and lessons learned.
Thank you. And maybe I should start by saying, how thrilled we are at URMC and at Wilmot that we have a leader, Edith Williams, that, as you heard, is putting us on a very strong track on the adjustments that needs to be done in our research enterprise. And, I'm thrilled to work and follow her leadership and guidance. So the issue of cultural language sensitivity, we hear you, and we hear the voice of the community. We hear the lack of trust when it comes to the research. And I just told you that we need to do much better in engaging the community in our clinical trials. I can tell you that here at this point, we have a commitment to action. As I mentioned, continuing the last question, just last year, 8 researchers who have never thought about engaging with communities, not with Paula, not with Edith, but directly, bi-directionally with the community, 8. We had 4 publications with the community. We had made important policy information with the community because we have the CCAC. We have been able, we are in the mall, we are really taking seriously. So I'm going to end with an example on how this, what happened in the past 6 months is transforming Wilmot. We had a new concept. Wilmot is known internationally about showing the role of yoga, a very affordable, high-reach intervention on clinical markers and survivors. But it hasn't been done in the community that needs the most. in the Black community. And let's begin a program, not only research. And instead of doing it, we went to the advisory board. We didn't have an advisory board. And then we invite the community to create the Faith in the Black Community Advisory Board. We went in, we didn't even know if yoga would be a possible way to address the disparities in survivorship outcomes. Well, we not only got an endorsement, but we got the guidance. We got the commitment of this advisory board to continue to meet and review every single research project that's going out before the projects are even conceptualized. New funding, pilot funding, because the community guide us with cultural sensitivity and language and community impact. We have created new pilot funding. We fund 3 projects focused on addressing and paying attention to culture. Because of the Black Community Advisory Board, we increase the treatment of smoking with our program in the Black community from 8% to 38%. We're currently in the entire treatment program that we have, which addresses social determinants of health, is culturally sensitive, is delivered to text message at home, no need of transportation, no need to appointments, 38%, and about 20% is quitting and smoking. We can only do this with the community and with this trust, and by being culturally sensitive, by not using one approach or not believing that we know how to do it. We put a program out. We are great. We're funding a tobacco program. No, nobody will come. But if we do it right with culture in the forefront. So we're taking this very seriously, and we're not nearly close. If we were, we wouldn't see the numbers that I shared with you before. So we know, but I can end here by saying commitment is not a word, it's an action. And we are eager to act now.
Thank you so much for that. And I agree, and I think I speak for all the panelists that we are committed to action. We're committed to partnering with the community and helping our community achieve better healthcare and to eliminate these disparities. I do want to look at our chat because we have a couple of questions that I would like to address. The first question is actually directed to all of our panelists. Any of you can unmute and answer this one. For our new American communities, how are we addressing barriers, for example, language, the stand on the way of accessing preventative health services?
I'm happy to jump in on that. From our vantage point, we facilitate translation. We do it in 2 ways. One, we facilitate translation services for people who have another language other than English as their primary language. And that's done through our daily, operations. However, we also recognize that there are large immigrant and refugee populations in several of our service areas. And we support community-based organizations that help connect those individuals to not only healthcare, but transportation, housing, as well as ensuring that they're able to get the information that they need in a language that is relevant to them.
Thank you.
If I could add here, just an element on the language, right? We are engaging in many translation initiatives. We know that we have so much more to do. But language, for us, and I know for all of us, it's more than the language, is about the culture, right? And how we're communicating. Spanish, there are so many different ways to communicate in Spanish. And so because there are cultures, there are ways of doing it. So I think that the barrier of language, we work at Wilmot very close with an advisory board of farm workers in its community that it's invisible, here. And so culture and language. I thank you for the question.
Thank you. We have another question from Victor Saunders. And this one, I think Dr. Jacobs may be the best one to answer this one. How do we as people of color change the mindset of our youth that something has to be wrong in order for us to make an appointment with our primary care physician or make sure we have a primary care in order to start building those important relationships? So basically, how do we tell our youth that they come and see us beyond just being ill or needing vaccines or sports physicals?
To go back to the beginning during the keynote address, is it has to start early. So making sure that moms have maternal care, making sure that during pregnancy, they are being seen. And I always recommend to expectant mothers to go meet pediatricians or family physicians, because that's the place to start. And then once you get connected, you start to build on that relationship. So it starts first with the parents, bringing the young people in early. So if I meet a baby and I follow that child, I do those vaccines that you mentioned, I do those school physicals, that is the beginning of the process. So most of those visits are well visits. So that's very helpful. So we started literally in the womb. So that's one place to begin. And one thing that I can say about Rochester, we definitely are on the cutting edge of health, because one of the things we do is we meet youth where they are. So school-based health, and Dr. Wilson is one of our gurus in this area. So we have clinics in elementary schools, high schools, and that's the place to begin. We need to see kids where they are. And one of the things also we have an advantage of is that physicals are required every other year in school by New York State law. So that's one way that we bring them in. And the other piece is that what's nice with the school-based health centers is they are facilities where they can go, but they always make sure that the individual students get a primary care provider. So that is key. And that's all about collaboration and communicating. And the other piece is to be at events like this. I was so excited to be invited to this because people see a face and they realize that, oh, wow, she's out there. I did not know that. And that's what's key, to have the word of mouth and for people to go around and say, oh, wow, it's really important to make sure our kids are safe. I recommend, and as mentioned earlier, faith-based communities are key. Do I go to churches and do I present at churches? Absolutely. Do I go to community fairs and people see me? Yes. And I respect all of my patients' privacy. I don't approach them ever out in public, but they do find me, even in my great masquerade disguise. Dr. Jacobs! And I feel like a celebrity. So it's great. And these may be the same very youth who have come to me for personal issues. They came in because something was bothering them, but then they felt comfortable and we were able to talk about when to come back and why to come back. And again, I think the other pieces that we can tag in on is a lot of times youth bring in a friend. So that's always exciting. And I always ask about the friend. So one young lady came in the other day and I'm like, who's this guy? Who is he? We just find him outside. Oh, that's my boyfriend. So we talked to boyfriend really quickly. We have to keep that communication open. And one of the things that we have to use to our advantage is social media. Even though I'm not a TikToker, I'm definitely not an influencer. We have to meet these young people where they are. Because if they see my face pop up, if I'm doing a TikTok, which is hysterical, it's different. I am human and I become someone who is trusted and you can ask me questions. So I think definitely kind of tapping into where they are, collaborating with schools, definitely approaching social media, and then making them feel comfortable.
Awesome. I wholeheartedly agree with everything you said and endorsing school-based health as well. One last question, and this is for Dr. Cuyler. Now, you had mentioned, and I actually underlined this multiple times, that there is no quality without equity. Can you just expand a little bit more on that? And I think that'd be a great way to end our panel.
Absolutely. We understand that one's attributes puts them at risk for experiencing certain disparities. And part of the work that is being conducted by NCQA when we think about accreditation programs revolves around understanding who the folks are that are going to be at risk. So doing risk stratification for basic things like pre and postpartum depression screening or mammography, colon cancer screening, et cetera. And what we are seeing an evolution of, not only with NCQA, CMS, and other agencies, is getting us to a place where we are not just collecting the data to identify who might be at risk for what, but then we're able to create solutions based on data that we gather from root cause analyses. And then we're able to implement the solutions and then go back and check to see how the data has changed. We hope that it would improve and we would see improved health outcomes, but it is that mindset of continuous quality improvement where we're gathering the data. I would say the important part in all of this is that we will need everyone to share information about who they are so that we can engage them with information about what risks they're at, what things they can do to mitigate those risks, and what resources are available for them to do that. And so historical data that we have not been comfortable trusting our institutions with, we're going to ask people to share that information so we collectively as a community can work together to start addressing these disparities.
Thank you for that. I don't know about all of those that are out there listening. I am so motivated, energized. Like if I started my day like this every day, I would just be ready to tackle on all of the problems and concerns that we have in Rochester to make this a better place. I can actually talk to these ladies for hours on end. We could sit with a cup of coffee, maybe a glass of wine, and just continue to talk about this. But I know that we have time constraints. We've learned so much about equity. We have learned about being in the moment, listening. We are focusing on our children. Where are they at? What is our village? Has our village changed? How do we redefine what our village is? We talked about transparency, being present in the community, understanding the data, collecting the data, holding those individuals accountable. There's no quality without equity. And understanding the new tools that Wilmot Cancer Institute is putting out there to help us address our burden of cancer, to get individuals in for screenings, diagnosis, and treatments to improve those outcomes, to talk about trauma-informed care so that our providers can be more educated and trained, and then how Excellus has so many opportunities for trainings and programs and awards out there for the community. This was amazing. I want to thank you ladies for joining us this morning. I think we've learned so much from you guys. And right now I'm going to turn it over to Jerome if he wanted to have any other closing remarks.
Wow. Me, thank you. Doctors by 5. This has been outstanding, and what a wonderful way to kick off this conference. And even going back to our keynote, if it's something we can all walk away with today, there's so many things, but how are the children? I think the Maasai said is Kiserian and Gera. How are the children? And for them, for the most part, they say the children are well, but for us, we know that is not the case. So back to our conference theme of empowerment, equity, and accountability, the journey ahead. We have work to do, and Doctors by 5 have outlined some work for us to do. And I think it was Dr. Cupertino who said, our responses must be culturally responsive, and commitment is a verb. It's actually an action. So we can't say we commit without doing something. And our hope, and I think I can speak for everyone in saying that hopefully 5 years from now, when we look at the data, that it's different, that the gaps are, if not disappeared, but they're much less. And as a matter of fact, as I was looking, and if we could bring the docs back up, there's a question actually from Sharita, and she muses, I wonder if rather than race and ethnicity being a risk factor if the actual risk factor is how the systems respond to race and ethnicity. Now, there's something to ponder. Let me repeat that. I wonder if rather than race and ethnicity being the risk factor, if the actual risk is how these systems, the various systems, respond to race and ethnicity. And I'll pause and allow any of our panelists to respond to that. We have 5 minutes, and even though, as I say that, I see Dr. Cuyler ready to jump on it. Just a reminder, we have the survey link has been put in the chat, and please go do that survey for us. I mean, data is important with respect to process improvement, and I guarantee you it'll take less than 5 minutes to do that survey. And as a researcher, I think Dr. Williams would agree 5 minutes is nothing. But to the question, like anybody to respond to Sharita's musing about the risk factor of how systems respond to people of color.
I would jump in on that, and I would, like to say we have to understand the role that the social construct of race and the creation of systemic and structural racism play in creating disparities. Bias is real, racism is real, and it plays a significant role when we're talking about disparities due to race. And so we have to, however, remember the intersectionality that drives the creation of disparities. We have to understand that we have to address policies, procedures, and practices. And it's not enough to just talk about change, but we have to reconstruct, redesign, change the paradigm to create a new way of doing business, a new way of caring for humanity. And so I would say wholeheartedly, absolutely, and quite loudly, yes, the systems and the structures play a significant role.
I agree with that. And I would take it one step further. When you're looking at a clinician, provider, or whatnot, we're often seen as the expert. And our patients are not seen as an expert. We tell them what we think they need to do, but they are the experts of their body and their lived experience. It should be a partnership. We should be listening more than talking more, as Dr. Jacobs has said. We need to build respect and trust with our patients. And it's beyond the racism and whatnot, but that definitely is a piece of that on how our patients are treated as soon as they enter our buildings. We need to change it from when they're greeted at the door to when we say goodbye. All of that needs to change.
Without a doubt, without a doubt. Again, just thank you from our moderator, Dr. Wilson. Excellent job. I'm looking at the screen. I'm like, am I watching CNN, NBC, or something like that? The quality of the content and the delivery, and Dr. Jacobs said, there's so much that all of us learn, and I'm sure that doctors learn from doctors today. Is that that iron sharpening iron is a real thing. It's a real thing. Empowerment, people have been empowered this morning. Equity, that's like our backbone, the spine. Accountability, we have to hold ourselves, as Sharita mentioned, accountable, and each other. Because again, if we're talking about the same thing a year from now, even a year from now, that's a problem. We're not doing justice to the people that we all serve. It's what my clock says, 10:58. We said we were going to give you till 11 o'clock this morning. Please rejoin us this afternoon. Come in early at about 1:45 if you'd like. But we start promptly at 2 o'clock this afternoon, where we have two panels. One is going to be looking at the impact of DEI over the past couple of years. This is an accountability panel going, so everybody's doing DEI. How has the community benefited or not? The panel is going to be looking at that. And after that panel will be an educationally focused panel, educational options for community, what? Empowerment, again, consistent with our theme. It's been a wonderful morning. I would be remiss if I didn't remind all of you participants to go to our website, abcinfo.org. Our awards breakfast will be on listen to me, January 26th, August. Anyway, such an august panel, that's what it was. January 26th, our awards breakfast will be held at the Memorial Art Gallery, and those tickets you can purchase them on our website. They're limited amount of tickets because we know COVID is still real. So we're not trying to pile too many people in there, but please, 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 there are a number of community folks who have earned our respect, and we will be honoring a number of them on that morning. We're going to sign off now. It's exactly 11 o'clock, but come back this afternoon. There's more. Empowerment, equity, and accountability. The journey is ahead. Thank you so much, everyone.